Good evening and welcome to our third session of our virtual patient education series, 2020 New and Emerging Treatments for Blood Cancers, with tonight's focus on MDS and AML. My name is Carrie Callis and I'm the program director here at the Leukemia Research Foundation. We're pleased to present this event in partnership with the Cardinal Bernardin Cancer Center at Loyola, and are grateful to have our presenters this evening, Dr. Khan and Dr. Dinner. We would also like to thank our supporters of this evening's program, AbbVie Jazz Pharmaceuticals, Karyopharm Therapeutics, and Novartis Oncology. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures, and enriching the quality of life of those touched by these diseases. Since its inception in 1946, the Foundation has raised funds to award over $80 million of research grants to over 500 new investigators on 5 continents, and supports patients and families living with a blood cancer diagnosis through educational and support programs. I encourage you to visit our website, allbloodcancers.org, to learn more about our patient support programs, including our patient grant program, our online support community, and our comprehensive listing of resources. So at this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff, who is the director at the Cardinal Bernardin Cancer Center at Loyola. Dr. Stiff is the chair of the Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the Foundation. So turning it over to you, Dr. Stiff.
Good morning, good evening, I should say. Don't know what time of day it is sometimes, and I hope everybody can hear me as well. So welcome to all of you. This is the third and final event. It's not a debate. Sorry if those of you were tuning in hope to have a debate. We're going to have answers is what we're going to have tonight. The first of the 3 sessions focused on myeloma and mature B-cell neoplasms. The second one on large cell and other non-Hodgkin's lymphomas. Tonight we're going to focus on myeloid disorders, or diseases that involve the bone marrow of the myeloid lineage, which are the white cells, not the lymphocytes, neutrophils, blasts, if you will. So acute myeloid leukemia and myelodysplastic syndrome, which for a time we called pre-leukemia because many patients ultimately transformed into acute leukemia. Again, we're going to have 2 20-minute presentations, and then we're going to answer questions for about 30 to 40 minutes after the end of both presentations. So we're going to answer again questions after both presentations are done. So we're going to run right through them one after the other. Again, I'd like to thank the Leukemia Research Foundation for sponsoring this. Patient information is a win-win. It's a win for patients. It's also a win for us because the more patients are educated, the more they'll be able to make informed decisions about which treatments are going to be appropriate for them, which treatments are going to be the best for them. And if they know more about the treatments before they come in to see us, they'll be able to say whether or not they're able to follow or tolerate a specific therapy because they'll know something about it. They'll know about the options. We used to call this the Treatment Options Conference. And certainly, again, you're going to hear a lot of options. What's really exciting over the last year and two has been the rapid advances in the management of patients with leukemias and lymphomas. Those of you who keep up with this are amazed, as we are, by the number of new drugs, new treatments that have been available for treatment of these disorders. I think there's been a couple new treatments just for myelodysplastic syndrome approved within the last year. And unfortunately, one of the big trials turned out to be a negative trial looking at alternate agents. But again, it's an exciting time because we are seeing some progress. We know more about the genetics of these diseases and are focusing on what we can do to mitigate the toxicity of these diseases, as well as the toxicity of the traditional chemotherapy that we've given for the last 40 years. Dr. Shira Dinner is a leukemia specialist at Northwestern Memorial Hospital here in Chicago. She focuses on acute leukemias, and actually she's known nationally for her work in acute lymphoid leukemia. It's a much less common leukemia, but she's developed a unique expertise and will be leading an upcoming national trial in this space. She, again, is at Northwestern, and I hope that we'll be able to be enlightened quickly by her expertise.
Thank you, Dr. Stiff, for the introduction and to the LRF for hosting this. So tonight I'm going to talk to you guys a little bit about new treatments for acute myeloid leukemia. So first, just some objectives that I hope to achieve for you: to define terminology that's commonly used in acute leukemia, some background on what AML is, to discuss some newly approved drugs for the treatment of AML in the last few years, and to identify strategies for optimal patient care. What's the best treatment for you, and should you consider a clinical trial? So first, some common terminology in leukemia. So we often talk about the difference between acute and chronic leukemia. So an acute leukemia typically develops from immature cells in the bone marrow that are called blast cells that do not function normally. The blasts replicate quickly and aggressively. They're what we would call clonal, meaning they're all the same, and they are overproducing themselves and not dying off like they should, since they're abnormal cells. The cells do not grow up into mature white cells, red cells, or platelets as we would expect them to, so they can't perform their normal function in the body, things like fighting infection, carrying oxygen to your organs, or preventing you from bleeding. In chronic leukemias, they can develop from an immature cell. Things like myelodysplastic syndrome is typically more chronic, but it can have blast cells, or more commonly mature cells, like we would see in a chronic lymphocytic leukemia or a chronic myeloid leukemia. But still, these cells do not function normally. These are clonal, abnormal cells that are reproducing and taking up space and resources in the bone marrow, and typically they progress more slowly in the chronic setting. So other things we need to consider is a complete remission. This is typically our goal when treating you. This would be absence of any signs of disease, and also less than 5% blasts in the bone marrow when we look through the microscope, and then no evidence of leukemia anywhere outside of the bone marrow as well. We now, these days, also think about minimal residual disease. This is a more common concept in acute lymphoblastic leukemia, but is sort of a hot topic in AML as well now. It's a very low level of leukemia cells, so less than 5% blasts, but they're still in the bone marrow, and we can't see them by the microscope. We could detect them by either following certain gene or chromosome mutations in your leukemia, or by looking at certain antigens, which are proteins on the surface of leukemia cells. We also worry about refractory disease, which is leukemia that's not responding to the treatment or did not achieve a complete remission, and then relapse disease, which means leukemia that was in complete remission but now has come back. And finally, what's our goal with clinical trials? So we're often talking about things like overall survival, which is the length of time from either the date of diagnosis of the leukemia or the start of treatment for a disease that patients are still alive. So in a clinical trial, this is a very meaningful measure of success because it tells us how well the treatment's working. We're not only getting you into remission, but are you living longer with that remission? And then progression-free survival is the length of time during and after the treatment of disease that the disease remains in remission and the leukemia does not come back or get worse. So what exactly is AML? It's an acute leukemia that's developing from myeloid blasts in the bone marrow, which I'll show you a little bit more of in the next slide. The blasts take over the bone marrow and prevent it from doing its job, as I had mentioned previously. So normally your bone marrow should make white cells, red cells, or platelets, and it just doesn't have the ability to do that because it's making these abnormal cells instead. So patients can ultimately have these complications of infection, anemia, and bleeding. But the important thing to keep in mind is getting a diagnosis of AML isn't the same for everyone. It's a very heterogeneous disease. We look at different chromosome and genetic changes that can make AML different for every patient. So the case at the bottom left is a 25-year-old who came in with low blood counts, large bruises, and bleeding issues, and was found to have a translocation between chromosomes 15 and 17. This is a very treatable form of leukemia called APL, and it's curable. The patient on the right is a 25-year-old, so same age, but is coming in with a high white blood cell count, increased growth of their gums, tumor lysis syndrome, normal chromosomes, but they have something called a FLT3-ITD mutation, and this can behave much more aggressively, has high rates of relapse and higher rates of death. So as you can see, two 25-year-olds with the same diagnosis of AML, they're still not the same. There are significant subtleties to their disease. So here's a chart that reviews what blood stem cells are and what they should become. On the right side, you can see that stem cells can become lymphoid stem cells, and then ultimately they're lymphocytes, which is a type of white blood cell to fight off infections. On the left, you'll see myeloid stem cells. These should become myeloblasts, which then become a neutrophil, which is pictured here. And they should also become red cells and platelets. But essentially what happens in AML is that your myeloid stem cell is stuck in this myeloblast phase, and it's copying itself inappropriately and proliferating and taking over space and resources in your bone marrow, so then you're not making your neutrophils, platelets, and your red cells. So in terms of the incidence of AML, it's the most common type of an acute leukemia that we see, and it's also really the most common leukemia that we see in the adult population. There are about 22,000 cases of it annually in the United States, and unfortunately 50% of those cases are going to end in death on an annual basis. As you can see, acute lymphoblastic leukemia to the left is much more common. There's only about 6,000 cases, and about 1,500 of them, or 25%, would end in death per year. And then a more chronic disease, chronic lymphocytic leukemia, while it has similar rates to AML of about 20,000, only about 4,000 or 5,000 of those patients are going to die from chronic lymphocytic leukemia per year. So it's a much more indolent and slow-moving or treatable disease. The 5-year survival for AML, unfortunately, can be poor. The median age when most patients are diagnosed is about 70 years old, and you can see in this graph here that patients between the ages of 65 to 74 have a 5-year survival of 12.5%, and those over the age of 75 have a survival of 2.6% at 5 years. So clearly there's room for improvement there for our patients. So what do we look at when making a treatment decision for you and talking to you about your prognosis? One of the important things we consider are chromosome changes. We categorize these chromosome changes into 3 different categories: favorable, intermediate, and unfavorable. So I'm not expecting you guys to know or memorize these chromosome changes, but I just want you to be aware that these are things that we keep in mind as your physicians, and that we have data that some treatments are going to be working better for some of these groups rather than others. Generally, favorable means it's better, or it's going to be less aggressive and more likely to respond to chemotherapy, whereas the unfavorable group tends to behave very aggressively, is more likely to be refractory to the chemotherapy or resistant, more likely to relapse, more likely to need something like a stem cell transplant for a cure. So these are just some graphs to illustrate the outcomes of the different chromosome risk groups. So as you can see, in terms of the incidence of relapse, the adverse risk group has a very high incidence. It's over 90%. Those in the intermediate risk group, it's about 65%, and those in the favorable risk group, it still is about 50%. In terms of overall survival, you can see the adverse risk group does poorly. Their survival at about 5 years is only 5%. In the intermediate risk group, that improves to about 25%. And then in the favorable risk group, we're at about 55%. The other thing we think about when considering your AML is certain gene mutations that can occur in AML. So I think of your chromosomes as a little bit like a roadmap for your body, and gene mutations are stops along the way on those chromosomes. Certain chromosome changes or breakage can result in mutations in genes, but sometimes also there can just be other changes that occur in the genes. We don't think that these changes in your chromosomes or your genes are things that you are typically born with. They're often things that you acquired during the course of your lifetime. But unfortunately, we do see them, and we think that they have roles in driving the leukemia and potentially have roles in prognosis and also treatments that might work for you. So on the right-hand side of the table, which lists some of the common gene mutations that we see in AML, and once again, not for the purpose of memorizing, but just so you guys can see them, and maybe one of these mutations has been identified for you by your physician at some point. It lists the overall frequency of these mutations. A FLT3 mutation is one of the most common at about 30% prevalence. And then this circle diagram on the left-hand side outlines for you some of the common mutations that we see in AML. And the length of the arc that's coming from it shows the frequency of those mutations that we see in AML, and then also the width of it is showing the frequency of other mutations that happen with it. So as I mentioned earlier, it's a heterogeneous disease. It's not the same for any two patients, and even for most patients, they might have more than one mutation. So even if we do give you a drug that targets the mutation, there could be another mutation that's also involved in driving the disease. So it is very complicated. So here in this table, I outlined some of the more common mutations, what we know about their prognosis, and if we have any treatments that can target them. So the most common mutation we see is a FLT3 ITD mutation. It's present in about 30% of patients. It does have a negative prognostic impact, so meaning that it's worse for patients to have it. We do have two drugs that can target it, though, midostaurin and gilteritinib. And there's also data that if you have a high level of the FLT3 mutation, that you could benefit from an allogeneic stem cell transplant when you're in your first remission. FLT3 TKD mutations is another variant of the FLT3 mutation. We don't know if it's a good or a bad thing necessarily. There's been inconsistent data in trials. We do have a drug called gilteritinib that's approved for relapsed disease that has this mutation. NPM1 mutations are generally thought to have a more favorable or a good prognosis. Actually, we don't think there's a benefit from transplant for these patients because they can do so well just with chemotherapy. And patients over the age of 60 have been shown to benefit from conventional intensive chemotherapy if they have an NPM1 mutation. DNMT3A mutations can also be seen frequently in AML and MDS. The prognostic significance we don't know clearly about. Some studies have said good, some have said bad. We do know that higher doses of daunorubicin improve survival as compared with standard dose daunorubicin in patients with these mutations. And also there's data that things like azacitidine and decitabine can work well for patients with DNMT3A mutation. A CBP alpha mutation is considered to be a positive mutation. We don't have anything that specifically targets it, but it is generally thought to be very responsive to 7+3 chemotherapy and consolidation chemotherapy. And then IDH mutations, we have an IDH1 and an IDH2. Don't clearly know the prognosis, but we do have drugs that are FDA approved for it in both the frontline and relapse setting. As well, there is some laboratory data to suggest, as well as clinical data, that these patients respond well to something called BCL2 inhibition, which is what a drug called venetoclax does. And then moving down to the bottom here, KIT mutations are thought to be more negative. They can be present in patients who have some chromosome changes like inversion 16 and translocation 821, which are usually favorable changes. However, if you do have a KIT mutation, that can somewhat negate those chromosome findings and make it a higher risk for relapse. And then finally, the P53 mutation, unfortunately, is a very aggressive mutation. Typically, P53 works to suppress tumors. But when it's mutated, it doesn't have that effect, and so the tumors can replicate in an uncontrolled fashion. So what have we accomplished for AML? How do we treat it in the last 40 years? So for a long time there, I didn't have a lot of good news to report to you. From 1973 to 2017, we didn't make a lot of progress. So 7+3 was accepted as the standard of care treatment in 1973. And in 1977, we decided that an allogeneic stem cell transplant also had benefit or survival advantage for patients when they got treated with it. And then finally, 40 years later, we identified several drugs that have been FDA approved in the last few years for AML, and I'm going to talk a little bit more about those next. So what are our general principles when approaching treating AML? So first of all, if we don't treat AML, it can be fatal for all patients. For some patients, if they're presenting with very aggressive disease and they've waited a long time before coming in to see the doctor, that could even be a matter of hours. For many patients, it's going to be days to months, just depending on how their disease is behaving. As I said earlier, it's a very heterogeneous or variable disease for patients, so it can behave differently for different patients. In terms of the goals, our hope is to achieve a complete remission and then ultimately to cure the disease. And while we have several new drug approvals, I would advocate that it's always important to discuss the possibilities of clinical trials with your physician, because while these are great new drugs, they're not perfect, and we do have room for improvement still. So first I wanted to talk a little bit about how we treat what we would call fit patients. These are patients who have good energy levels, they're eating well, and typically we would say that they could spend at least 50% of the day out of bed, up and active, maybe even doing things like light housework, just because going through an intensive induction chemotherapy like 7+3 can be quite exhausting, and there are a lot of complications associated with it as well. So we give the induction chemotherapy in order to achieve what we call an MRD negative remission. So we don't want to see that little bit of leukemia that's not visible through the microscope that we can detect through other means, such as genetic testing and flow cytometry. We also want to convert that remission into a long-term cure. So we do that by giving initial chemotherapy. People often ask, I got chemo, I got one cycle of chemo, I'm in remission, why do I need more? If we don't give you more, it's going to come back absolutely. And then for some patients, we need to consider an allogeneic stem cell transplant, or else there's a very high likelihood of relapse. So this is just to highlight the importance of minimal residual disease. So what you can see in the graph on the left is that the red line shows patients who have active AML, so meaning that it was refractory or didn't respond to treatment. The gray dotted line shows those who are MRD positive. So they are technically in a complete remission, but they do have a very low level of disease that we can detect. And unfortunately, as you're seeing, they do just as poorly as those who have active AML. If we look at this table on the right-hand side, you can see the 3-year overall survival is comparable between those who have an MRD positive remission and those who have active AML, only about 25% at best. And a 3-year progression-free survival, meaning timing until the leukemia comes back, of about 12%. So it's very important that we achieve a deep response. So what are some of the treatments that we can use? 7+3, as I said, in 1973 was the approved treatment, and we've made some strides since then. In 2017, the FDA approved a drug called Vyxeos. Vyxeos is for newly diagnosed therapy-related AML. This is a type of AML that developed because someone previously had radiation or a chemotherapy for a prior cancer, or rarely for some autoimmune diseases. Or AML with MDS-related changes, which is AML that arose from a prior myelodysplastic syndrome, or AML that might have been diagnosed as having MDS-related changes because of appearance of the shape and size of the cells under the microscope, or certain chromosome changes that we can see in MDS. So what Vyxeos does is it combines cytarabine and daunorubicin, which is the agents you would normally get in 7+3, but it's giving them in a single, what we call liposomal formulation. So that's essentially a fat bubble that's wrapping these two drugs up into one drug. And it's been shown that it might help these high-risk patients. Typically, patients with therapy-related AML and MDS-related changes can be very aggressive and don't respond well to 7+3. The median overall survival with Vyxeos was 9.56 months, compared to about 4 to 5 months with 7+3. And there were better outcomes also for those patients that achieved a complete remission with Vyxeos and went on to transplant, compared to those who achieved a CR with 7+3 and went on to transplant. So I think, this study didn't measure minimal residual disease, but I think it's touching on the importance of that minimal residual disease, and one could hypothesize that maybe patients were getting to be MRD negative with Vyxeos, and that's why they had a better response and ultimately better outcomes even with transplant. Side effects are pretty common to what we see with chemotherapy, including bleeding, fever, infection, nausea, vomiting, mucositis, which is breakdown of the lining of your mouth or your gut, diarrhea, and fatigue. Sorry, it doesn't look like my slides are advancing. Okay, there we go. So what do we consider as therapy for unfit AML patients, that's sort of newly approved therapy? So our general goal is to try to also give an induction to achieve a remission. However, this is usually a less intensive treatment, and we acknowledge that we're probably not going to get to the point of cure. We call this a palliative treatment, meaning that it could get the leukemia into remission, it could prolong your overall life, but there's still a very high risk that the leukemia in the long term is going to come back. And so what we're aiming to do is to achieve a good quality of life and hopefully transfusion independence, meaning that you don't need blood or platelet transfusions, and hopefully that you're not neutropenic, so not at such high risk for infection. So one of the first drugs that was approved by the FDA was Glasdegib. It's an inhibitor of something called Sonic Hedgehog, obviously not a video game character. In this case, it's a protein that's present at very high levels in many types of cancer. And so this drug is blocking or inhibiting that protein and then causing the cancer cell to die. The FDA approved this drug in 2018. It's an oral drug that's given by mouth daily, and it's given in combination with low-dose cytarabine injected under the skin twice daily for 10 days. It's specifically for newly diagnosed AML over the age of 75 who are unfit for chemotherapy. So they define that as having severe heart or coronary problems or coronary artery disease, kidney problems with a high creatinine, and a poor performance status. So meaning like you can't do things like get out of bed for more than 50% of your day. The median overall survival was 8.3 months, which was better than the control arm of low-dose cytarabine alone, which was only about 4 to 5 months. And the side effects were anemia, low platelets, fatigue, bleeding, fevers, muscle pain, anorexia, change in taste, mucositis, and rash. Now, at the same time, the FDA approved another drug for patients who are unfit for intensive chemo. This is called venetoclax. Venetoclax works differently than Glasdegib. It blocks something called anti-death B-cell lymphoma 2, or BCL2, which is a protein that's found in many cancer cells. And so as it describes itself in its name, it's an anti-death protein. And so blocking it, it causes the cell to die. And it's also approved for patients who have untreated AML, who are over the age of 75 or are not fit for intensive chemotherapy. Venetoclax with azacitidine or decitabine was studied in patients who had new AML, so no prior things like MDS. And venetoclax with low-dose cytarabine also allowed patients with a history of MDS who had received prior treatment with azacitidine or decitabine. And they just did a phase 3 trial that looked at venetoclax and azacitidine versus azacitidine alone, and it showed that those who got the venetoclax with azacitidine did have a significant improvement. Their overall complete remission rate was 66%, and the median overall survival was 14.7 months, whereas it was less than 1 year with azacitidine alone. Side effects were nausea, low blood counts, fever, pneumonia, sepsis, and bleeding, and we definitely see that low blood counts are a big thing that can impact patients with this treatment. So, how would I as a clinician pick between Glasdegib and venetoclax in terms of treating you? Overall, I would say that the median overall survival was better with the venetoclax and drugs like azacitidine or decitabine and low-dose cytarabine. So that would be my first choice, but we also do consider Glasdegib as an option for patients, whether it's related to things like drug interactions, side effect profiles, or if you've had venetoclax and things like azacitidine and you're progressing on that, we could consider Glasdegib and low-dose cytarabine as another treatment option for you. So then there's also oral azacitidine, which was just approved in September for patients who are unfit for intensive chemotherapy. And you might say to me, well, why can't I get an all-oral regimen? Typically, azacitidine, decitabine, and low-dose cytarabine are either injections or they're IV infusions. So specifically, the way that oral azacitidine was studied is as a continued treatment of patients who achieved complete remission, initially with an intensive induction chemotherapy regimen, such as 7+3. But they weren't able to complete their intensive chemotherapy treatment because they weren't tolerating it well and they weren't fit to get more intensive treatment like high-dose cytarabine consolidation and a stem cell transplant. So it's approved as a maintenance therapy after getting into remission. The median overall survival with oral aza was 24.7 months compared to 14.8 months with placebo, so just observing patients and not doing more treatment. And the side effects were nausea, vomiting, diarrhea, fatigue, constipation, pneumonia, abdominal pain, arthralgia, decreased appetite, and neutropenic fever. And so the way it's generally recommended is to use after someone's already gotten into remission. So one could consider it in theory after you get into remission with something like IV azacitidine or decitabine and venetoclax. However, I do caution you, and it's something you should talk to your doctor about, that oral azacitidine has not been studied with venetoclax. So these two oral drugs could interfere with each other. One could affect the absorption of the other. It could increase the levels or decrease the levels. We don't have any data in terms of efficacy, so in terms of how it could impact survival outcomes, we just don't know that. So then moving on to more specific treatments that block particular mutations. The ones I presented to you just now were those that are kind of generally available to the AML population, but they don't focus on any particular mutation in AML. So first we'll talk a little bit about FLT3 and then move on to IDH mutated AML. So FLT3 mutations are present in about 30% of AML. And what I put here on the right-hand side is a little bit of a diagram of the FLT3 receptor. It's present on the surface of the AML cell. This little line with the yellow and blue is supposed to be the cell surface. And then you have a receptor that goes from the outside of the cell to the inside of the cell. And the mutation can occur here in this part of the receptor. And then basically it's like flipping a switch. It turns the receptor on and it's constantly signaling inside the cell that the cell should continue to live and it should proliferate or multiply. And so what midostaurin does, here it's represented here, it's right after the brand name for it, it blocks, it sort of binds to this part of the receptor and it blocks it from signaling and it causes the cell to die. So the FDA approved midostaurin in 2017 in combination with 7+3 for newly diagnosed FLT3 mutated AML. The median overall survival was remarkable at 74.7 months with midostaurin versus only 25 months with placebo or getting 7+3 alone. Side effects were neutropenic fever, nausea, mucositis, vomiting, and bleeding. So this is one of the first success stories in terms of it is an intensive treatment. But adding a molecularly targeted therapy to block a specific mutation to 7+3 and having a very significant survival benefit. So we were fortunate to have another drug called gilteritinib approved for FLT3 mutated AML as well, just a year later in 2018. Gilteritinib is an oral drug that you would take by mouth continuously daily. It's given by itself, not in combination with chemotherapy at this time. It did have a complete remission rate of 34%, which is very good for this relapse population. They often don't respond very well to chemotherapy. 31% of patients became transfusion independent, and the median overall survival was 9.3 months. Side effects were muscle and bone ache, fatigue, and liver inflammation, not that patients felt, but that were noticed on blood work. And currently there are a lot of combination studies in process. So looking at gilteritinib in combination with 7+3, as well as looking at gilteritinib in combination with newer drugs, venetoclax, for example, such that we can try to see, can we increase the efficacy of the gilteritinib beyond that 34% remission rate and also hopefully improve the survival outcome. So then moving on to IDH mutations. So IDH mutations prevent the DNA from making genes that are important for myeloid stem cells to mature into functional adult blood cells. So when you block the IDH mutation, essentially it can allow those cells to go on and mature into those adult cells, things like white cells, red cells, and platelets. So in July of 2018, the FDA approved the IDH1 inhibitor, ivosidenib, which is an oral drug for relapsed refractory IDH1 mutated AML, had a complete response rate of 33%. The median time to response was 2 months, so about 2 cycles, and the median response duration was 8.2 months. 37% of patients became transfusion independent, and the side effects were fatigue, high white cell count, bone aches, nausea, diarrhea, constipation, swelling, mucositis, and changes in heart rhythm. There was also differentiation syndrome. And so what that is that when these cells are suddenly unlocked from being in a blast state and are maturing very quickly, and a lot of them become mature adult cells at the same time, can cause a lot of inflammation in the body. And that can result in some fluid in the lungs, some failure of the kidneys. And so it's very important that if you are on this drug, that you're monitored closely by your treating physician. They can do things like stop the drug or give you steroids in order to treat that. As well, in 2019, the FDA expanded their approval of ivosidenib for newly diagnosed IDH1 positive AML in older adults who are unfit for intensive chemotherapy. The complete remission rate was 43%, 41% became independent of transfusions, and currently there are studies of combinations going on, things like azacitidine and ivosidenib, or even azacitidine, venetoclax, and ivosidenib. So it is a nice all-oral option for some older adults who might not want to be getting an IV chemotherapy. In terms of IDH2 mutations, so in this case, an IDH2 mutation works the same way as an IDH1 mutation, and we have just a different drug to block it, enicetinib. It was approved in 2017 by the FDA for relapsed refractory IDH2 mutated AML. It achieved a CR with or without count recovery in 23% of patients, and the duration of response was a median of 8.2 months, and the median time to best response was 3.7 months, and 34% no longer required transfusions. And the NCCN National Comprehensive Cancer Network does also recommend this as an option for frontline treatment of IDH2 mutated AML. So then finally, I want to talk to you a little bit about immunotherapies. I think this is perhaps where some of the newer AML treatments will move in the next few years. Something that's been around for about 10 years now is a drug called gemtuzumab ozogamicin. It was initially on the market and then was pulled from the market, but subsequent trials validated it and it was brought back in the last few years. It's an antibody against CD33 on the surface of the AML blast cell, and it's linked to a toxin. So this sort of Y shape here is your antibody, and then there's this linker protein, and then there is a toxin that's attached to it. So it binds to this CD33, this little orange circle on the surface of the AML cell. It gets taken into the cell. Some of the enzymes or the chemicals inside the cell degrade it and release toxin into the cell, and it kills the cell. So it's FDA approved for fit AML in combination with 7+3. It improved event-free survival to 17.3 months, in particular for patients who had favorable risk chromosome changes. It's also FDA approved for newly diagnosed elderly unfit AML. However, the median overall survival is short at 4.9 months, so I would say I would probably favor either venetoclax with something like azacitidine or even glasdegib with low-dose cytarabine over this. And then it's also FDA approved for relapsed or refractory AML. It had a 26% complete remission rate and 11.6 months relapse-free survival, so meaning the time until the disease came back. And, currently additional immunotherapies are under investigation, in particular ones that not only use an antibody to bind to the surface of the leukemia cell, but are actually trying to do things to activate your immune system to attack the leukemia cell. And we do have clinical trials for that I can answer questions about if you're interested. So to conclude, what's the best treatment for you? Importantly, every case is different. As I discussed, there's a lot of chromosome changes, a lot of genetic changes that can distinguish your AML from another person's AML. You have to talk to your physician about these changes, these mutations, and to better understand what treatment might be best suited for you. One of the newly approved treatments might be right for you based on this available information that they get from your chromosomes or your genetics. And then I think it's always important to talk to your doctor about a clinical trial. First of all, the drugs we discussed today were approved based on very recent early phase clinical trials. So I want to emphasize that in terms of if you're afraid of the idea of a clinical trial. You're not just being a guinea pig. There is scientific rationale in terms of why they're investigating it. Many times there's even early phase clinical data for the drug, and never would they deprive you of getting treatment. So never are they going to give patients an absolute placebo. You would always be getting some sort of treatment. It might be a standard of care treatment, but it might also be a standard of care treatment with a novel or new drug added to it. And then also newly approved drugs are now in clinical trials in combination with other novel or experimental drugs that might improve their outcomes. So I would encourage you to consider it. And with that, I'll take any questions that you guys might have.
So again, we'll do questions after both presentations. Thank you very much for a very comprehensive presentation. Thank you. Is Irum Khan, who's Associate Professor of Medicine in the Division of Hematology Oncology at the University of Illinois here in Chicago. She is also, I will tell you, a funded researcher for the Leukemia Research Foundation. As Carrie mentioned, one of the main focuses of this organization is to fund cutting-edge research, and Dr. Khan submitted a grant and was funded for her groundbreaking research in the area that she's going to talk about tonight. So maybe she'll touch on that a bit. So without further ado, we're going to welcome Dr. Khan to do her presentation. Thank you again in advance for doing this for us.
Once again, thank you for your patience and thank you for the invitation. It's always great to be at this meeting. And this time we got a sneak preview at the questions, which was great because some of them were really thought-provoking. So I'm going to talk to you about myelodysplastic syndromes. And just on my introductory slide, I kind of wanted to show you there's a really nice review published this year by an Italian hematologist in the New England Journal, and this picture really summarizes some of the conundrum we're dealing with when we try and diagnose and determine what is the best treatment for our patient. So really, what we're talking about is a continuum of normal blood production to leukemia, and MDS, we're in the middle. So with the top panel is just normal blood production, where this stem cells in your bone marrow give rise to different progenitors that have a fate to become a red cell, a white cell, or a platelet. And then along the way, you can acquire a mutation in one of these early stem cells, which may actually be very inconsequential. It may be detectable with our newer technologies, which can pick up very low burden of mutations of less than 10%. And some of these are very inconsequential, and so that's some of the conundrum in figuring out what's consequential and what's not. And so CHIP is really clonal hematopoiesis of indeterminate. You have a clone, we have no idea what it's doing, but you seem to be making blood just fine. But as it progresses, and not everyone progresses, in fact, the very vast minority progress, they may acquire additional mutations where now actually there is really an effect on the process of maturation, and the bone marrow starts to accumulate abnormalities, so that when a pathologist looks at it, they say, all right, this doesn't look right, cells are abnormal. And you can stay there also, you can hang out there for a long, or you can then go on to develop additional mutations that give some of those cells a real advantage, where they really start to take over, and you start having this very monotonous looking bone marrow where all the cells sort of look the same, none of them are developing. And then when you have 20% or so of these cells, that becomes acute myeloid leukemia. So just to bear in mind, this is a continuum, and what Dr. Dinner was very nicely summarizing was the treatment for leukemias, but I'm going to focus a little bit on this phase of MDS. All right, let's see. So when we talk about just the epidemiology of MDS, as with most malignancies, it's a disease of the aging, because it's usually the acquisition of mutations, as I showed you, which tends to increase with age as our mechanisms to identify mutations and rectify them or eliminate them slow down. So the overall incidence is 5 per 100,000, but as you get over 70 or 80, that may approach more like 20 to 30 per 100,000, making it the most common of the myeloid malignancies. I like this slide, and I frequently show it because I think it really nicely captures some of the challenges that patients as well as physicians face when dealing with MDS. It's a very heterogeneous group of diseases, and a patient can hang out in a very low risk stage for a long time. And so this is just a depiction of what would happen if 100 patients were diagnosed today, and sort of how it would bear out for them over the course of their life. So if we look at the first 6 here, they would be high risk at presentation. We would consider a transplant up front, out of which 2 would be cured, 3 would relapse in the green, and 1 would have transplant-related complications. 12 patients would die of bleeding-related complications related to low platelets, so not the majority. 2 would have iron overload problems, which happens as a consequence of both the transfusions we give, as well as just the fact that red cell production is a little bit ineffective in MDS, and there's a lot of abnormal iron metabolism. 20 patients of that 100, so that's a fifth, will have infectious complications that will be fatal. We'll have anemia-related complications, meaning low red cells leading to heart attacks and strokes and organ dysfunction of that nature. 24, so that's the vast chunk, the ones that will have complications, will progress to AML. And that's what we really want to prevent. And we need to identify these patients as early as possible, because out of these, if you do try and treat them once they become AML, they are a subset that tends to be a little bit more resistant to treatment, and transplant outcomes are a lot more modest than if they were transplanted in the MDS phase, or if they had AML that did not arise from pre-existing MDS. And lastly, just to remember, 29 of these, so almost a third, will have completely unrelated causes, like geriatric causes, that will lead to their ultimate demise. And so not everybody needs something, unlike a lot of the malignancies we think about. So how do we tease through these very different clinical courses? So traditionally, we've relied on clinical and cytogenetic markers, and these include, and these comprise what we call the RIPSS, or the Revised International Prognostic Scoring System, which I've just summarized here. It's a scale of basically I guess it goes up to over 6, but we add up all of these points. And I think it's important to know it's been revised over the years to really give a little bit more weightage to the percentage of blasts, which are those immature cells in the marrow, as well as the cytogenetics. So the chromosomal architecture, just like Dr. Diener mentioned in AML, are heavily driving outcomes in MDS. So we really look at those very carefully. And really anything above a 3.5, we start thinking pretty quickly about transplant if possible. And in recent years, like in AML, the identification of mutations have added value to our ability to prognosticate. And while a number of mutations are still difficult to interpret, there are a few that have been able to independently add value to our existing prognostic scoring system. And so 5 mutations were identified in 2011, which include P53, which we'll talk a little bit about, and a few others like ASXL, RUNX1. These tend to add an additional point to the traditional prognostic scoring system. So low risk in the absence of a mutation lies here, but it kind of, in the presence of one of those mutations, joins the intermediate risk and so on. So everybody gets an additional point. So there's some value in looking for these mutations if they are well validated. So to answer the question of, do I care about the genomic characteristics of my disease? So there's, a lot of data that we get when we start looking for mutations. And really, as I showed you, a number of people can have a clone that's completely inconsequential. So really discerning something that's a bystander to something that's going to cause a problem is complicated, but I think there is value. And so we know that about 90% of patients carry some mutation. Majority of these are in splicing factors, which is how the cells handle RNA. So DNA has to be turned into RNA, which is then turned into protein. So that machinery is disrupted very commonly in MDS. And then DNA methylation is a second pathway, and that's which genes are turned on and off. So these are very global mechanisms that are altered and are probably sort of disease drivers of MDS in general. As I told you, these 5 mutations have an adverse prognostic value, so they help us triage somebody we might be on the fence about to something more aggressive like a transplant. And then there's actually a favorable mutation in factor gene called SF3B1, which tends to predict a better outcome in low-risk MDS, but also now responds to a treatment, which we'll talk about. And as Dr. Jenner mentioned, a lot of do with clinical context and multiple coexisting mutations. So it's not straightforward. And lastly, targeted therapies, which are sort of the utopia for us all. Some of these mutations are leading to that. As we learn what they do and the pathways that they make the cells vulnerable to, we develop targeted therapies. And that's where the IDH1 and 2 inhibitors come into play, which are present about 10% of MDS patients. And then P53 mutations, and we'll talk about a novel class of drugs developed here, which I think is pretty exciting. And splicing factors, of course, is very tempting to target because it's the chunk of MDS. It's been challenging, but there are spliceosome inhibitors that are in early clinical development. And so I think that's an area that's scientifically very interesting. We have yet to see how effective it is as it moves forward clinically. So just kind of broadly, when we think about MDS, we think about the low risk and the high risk, and that's based on that IPSS score that I showed you, where the low risk, really we're interested in trying to improve our patients' blood counts, reduce iron overload, and improve their quality of life, because we know that their survival is not impacted early on. Whereas high-risk MDS, we're talking about a pretty high risk of progression to leukemia, and all our attention is directed toward delaying that and trying to actually cure them prior to that and improve their survival. So when we talk about low-risk MDS, the commonest presentation of that is anemia. Most patients have low red cells, far more so than low platelets. And so an early sort of mainstay of treatment has been, in addition to blood transfusions, giving agents that stimulate increased blood production. And those are erythropoiesis stimulating agents like erythropoietin or darbepoetin, which stimulates progenitor cells in the bone marrow to make more red cells. And these have been used in the United States based on phase 2 data, but in Europe, they recently conducted a phase 3 study very clearly showing that patients randomized to getting epoetin, which was their formulation there, versus placebo, had a markedly improved transfusion-free survival. So again, the outcomes in these studies are usually freedom from transfusion, not survival, because that's not the problem with low-risk MDS. And the Nordic group came up with a way to predict who would respond to these drugs. And it's usually the patients who are not so heavily transfusion dependent, so needing less than 2 units a month, and with low erythropoietin levels of their own. Because if they're making their own erythropoietin, because this is a hormone that the kidneys make, then they're probably saturated and more won't help. So there are some things that we can use to decide if this is going to help, but it's a relatively low risk intervention and can give responses of over a year, sometimes up to 2 years. It's important to realize that if you drive the hemoglobin up too high, there is a risk of blood clots, and so we always watch where the hemoglobin is. For patients who progress on erythropoiesis-stimulating agents or for some reason don't respond to them, various immune suppressive agents were explored, and one of them was lenalidomide, which is a drug you know probably from the myeloma literature. The IMiDs are drugs that affect the immune system, but they were found to be very effective in a subset of MDS patients that have an abnormality in chromosome 5q, which is the one arm of chromosome 5. And in patients with this subset, they found really high responses and did a dedicated clinical trial in patients with just this genetic abnormality. As you can imagine, that's a big undertaking because this is not that common a subset. But they were able to show that 50% of patients on low doses of lenalidomide, they tested 2 doses, 5 and 10 milligrams, had up to 50% response rate compared to placebo, which did not. And again, responses are really transfusion independence, which continued for a couple of years for the median, so 50%. So that was pretty impressive and led to, and this was identified pretty early in 2006, and so this drug is FDA approved for this indication. In the and the reason for this benefit is because there is a gene on 5q that's missing that makes these cells particularly vulnerable to affecting a pathway that lenalidomide affects. So it's based on a chromosomal change. For patients without 5q, it has also been looked at. The response rates are a little bit more modest, more in the range of 25 to 30%, and a shorter duration of response, more like 30 weeks compared to 100. So certainly when you have a drug with a clear-cut target, it will be very dramatic. Now there's a drug which is very exciting because not only is it pretty effective, but it's also very well tolerated. So this is a first-in-class drug which targets TGF-beta. TGF-beta is basically a sort of short-lived hormone that when it binds to its receptor, it can prevent red cells from finishing maturation. So they get kind of developmentally arrested. They're almost mature, but they don't make that final step to make the red cells. And so if we were able to prevent this interaction of TGF-beta with its receptor, we could release the cells from that block. And this pathway called SMAD, which is really the pathway that's making trouble. And so they devised a drug that basically mimics the receptor in part, and the rest of it is fused to a human immunoglobulin sequence. And it's a trap, and it binds to all the ligands so that the ligand cannot bind to its natural receptor. And so that SMAD pathway is not activated, allowing red cell production to take place normally. And so this results in a pretty impressive improvement in hemoglobin. And this happens relatively early within the first 2 to 3 cycles and is sustained, as you can see here, going on to week 25. This is a drug versus placebo in the phase 3 Medalist trial. And this led, and the response rate, like 40% of patients almost were transfusion independent compared to 13% in placebo. And that resulted in this drug being given FDA approval in April of this year. I think it's important to mention that the phase 2 studies showed that really this works in patients that have that spliceosome mutation called SF3B1. And so the phase 3 study was done in patients that had that mutation or physical evidence of abnormal red cell production, which is called ring sideroblasts. So it's patients with ring sideroblasts or this SF3B1 mutation that were given this drug and had this response. Immunosuppressive therapy has been around for a long time in MDS. It's only a subset of MDS that really responds, and that's pretty clear in this retrospective study done across over 10 countries. They looked at 207 patients treated with immunosuppressive therapy. The idea being a subset of MDS is related to a dysregulated immune system, and so maybe suppressing that allows normal blood production. And they saw that response rates were in the range of about 50%, because if you include the remissions as well as hematologic improvement, that's about half the pie. This is 207 patients, so it took 15 countries, and this is very few patients. So this is not a common modality used, but for the responders, they did improve their survival. And when they look to see who really responds to immune suppression, it's patients that have a very empty bone marrow, which is called hypocellular. Most of MDS patients have a very full bone marrow because the cells are trying really hard to divide and make blood, but they're ineffective. But about 10% of patients have an emptier bone marrow, looking more like aplastic anemia, which is a benign disease. And so these guys are somewhere in the middle of a benign and malignant process. And their survival and the risk of transformation to leukemia, shown in these graphs on the left, in the red, is sort of intermediate between that of aplastic anemia, which is green and has a beautiful survival curve, and then hypercellular MDS, which has a less favorable survival curve. So hypocellular somewhere in the middle, and may respond to immune suppression. So I think that's important to consider. And within the immune suppression, it was cyclosporin and ATG that seemed to work best. Then we also have a small subset of MDS patients that have problems with low platelets and bleeding. And so for those patients, there have been studies done drugs that stimulate signaling through the normal receptor called the thrombopoietin receptor, which stimulates platelet production from stem cells in the bone marrow. There's 2 drugs that have been studied in MDS, romiplastim and eltrombopag. Romiplastim is an injectable drug, eltrombopag is a pill. Romiplastim got a little bit of bad press initially because there was some concern that it was stimulating blast cells, and they had transiently increased. There have been a number of long-term follow-up studies that did not bear out. Eltrombopag has been studied in 2 phase 2 studies with no significant increase in risk of leukemia, and this is an oral option. And these are the platelet responses, which you can see, within days go up quite nicely, 47% versus 3%, and a significantly reduced risk of bleeding events. So this is a really good option for patients with low-risk MDS and low platelets as their main problem. Lastly, we'll talk about iron overload, which is a problem in low-risk MDS. And so it's always been talked about that maybe if we soak up some of this extra iron, we can prevent long-term damage to the heart and to the liver. And so a phase 3 study was recently completed and published in the Annals of Internal Medicine, showing that patients with iron overload had decreased event-free survival. And that endpoint was a composite of liver damage, heart damage, and transformation to AML. So they kind of looked at a lot of endpoints together, which probably is a bit of a statistical tool to make a study successful. But it's pretty clear that the iron levels as measured by the ferritin came down quite nicely with the medication, and there was some clinical benefit in a phase 3 study. So I think this is a very reasonable option. Coming to high-risk MDS, here we're going to start hearing about a lot of the drugs that you've heard about from Dr. Dinner. So I'll be a little bit quicker here. So high-risk MDS is on the continuum to becoming AML. And so we really think very quickly about transplant in these patients. For the transplant-ineligible patients, the first line of treatment is hypomethylating agent, which includes decitabine and azacitidine, approved in 2004 and 2006, respectively. And after that, there was a real dry spell in AML with a lot of trials, none of which really were able to better or improve on the outcomes of hypomethylating agents. But we finally, every dog has its day, and we got a drug. So we got an oral formulation of decitabine in combination with cedazuridine. And so cedazuridine is actually an inhibitor of an enzyme that rapidly inactivates oral decitabine. So in the past, attempts to give decitabine orally have resulted in very variable blood levels because it gets broken down so quickly. And attempts to inhibit the enzyme have been pretty toxic. So this was a real breakthrough to have a combination of a drug with an enzyme that allows that drug to maintain good levels in MDS. And so what they looked at was really the studies that led to the FDA approval of this oral formulation of decitabine were really comparing the pharmacokinetics of the two formulations, because it's exactly the same drug, but you just want to make sure that the levels are elevated. And the dosing schedule is actually exactly the same. So it's 5 days, either IV or oral. And so the way the trial was done was patients got either the oral or the IV formulation in cycle 1, and they switched in cycle 2, and then everybody stayed on the oral formulation cycle 3 onward. And a lot of these patients had already been on the IV formulation, suggesting that, patients who are on a very stable dose of the IV formulation can be switched to the oral. So this is really nice for our patients now, because instead of, being on an indefinite treatment for which they have to come to clinic every single month, they still have to come to clinic to get blood counts and monitoring, but now their medicine can be a pill that they take at home for 5 days of the month. So I think this is an exciting development and really helpful for the quality of life of our patients who, have a disease that's going to require a prolonged course of treatment, because majority of these drugs work for well over a year. A drug that's actually really interesting for the subset of patients that we've all found challenging, whether it's an AML or MDS, is patients that have the P53 mutation. And this, as Dr. Jenner mentioned, is a mutation that is very important for cells to undergo death when damaged. And when this gene is abnormal, cells can take a lot of genetic hits and damage and not die. So you have the cells just collecting, getting a lot of damage from chemotherapy, but not dying. And so APR-246 is a first-in-class drug that was recently presented at our annual ASH meeting in combination with azacitidine. What this drug does is it binds to the mutant form of P53, so really the culprit protein that's not doing its job, cell to die, and it changes structurally by binding to some of the residues, some of the amino acids in it, and shifting its equilibrium so that it goes back to the normal, or what we call the wild type state of the protein, and does its job, which is really arresting the cell cycle and causing the cell to die, which is apoptosis. And so this was really exciting because in the phase 2 study that was presented at ASH this past December, you can see here out of 45 patients, 33 were MDS patients, and the overall response rate, and these are all patients that had a P53 mutation, 88%, which is pretty much kind of unprecedented in this disease. And they actually showed nicely that the mutation burden, as checked by the DNA sequencing, became undetectable. So that's called molecular remissions, and those were seen in about a third of patients. And a number of these, 52%, went on to transplant. So and the follow-up is pretty good, 10.8 months. So this is really encouraging data for a difficult to treat population. Venetoclax, you've heard about already in AML. It was looked at in patients with relapsed refractory MDS, meaning patients who had already been on hypomethylator and then it stopped working, which can happen within, on an average, 1 to 2 years. And you can see that the combination had response rates of 40%, which is kind of encouraging because you just add on the venetoclax to somebody who's already on azacitidine. It's an easy enough intervention. And you can rescue a third of them and put them back into some semblance of a remission, and then prolong their survival secondarily. So that, I think, is interesting and important after progression on hypomethylator. And then just talking about a couple of additional targets that are unique to, netylation at least is unique to MDS. Netylation is a pathway that's relatively new and kind of seems more relevant in blood cancers compared to other cancers. It's a pathway whereby proteins get targeted for destruction. So normally there's a lot of turnover in cells, and the cells have to destroy proteins, otherwise they accumulate and kill the cells. And so the way they do that is they put a tag on them called ubiquitin, and then they go to the garbage disposal system of the cell, which is called the proteasome. Netylation accelerates this process by activating this critical enzyme called cullen-3 ligase. And so by netylation with this drug called pevonedistat, abnormal proteins accumulate because they cannot move forward to the trash can and be destroyed. And so this is the early phase 1 trial of a patient getting the drug, where you can see that the drug forms, this is pre-treatment on the left and post-treatment on the right. And you can see that the drug forms the adjunct with its target after treatment, and results in the accumulation of CDT1, which is a protein that starts to build up in the bone marrow, and that buildup eventually causes the cell to die. And it was seen that that this drug synergized really well with azacitidine. And so at ASCO in June this year, they presented the results of the phase 2 study combining pevonedistat with azacitidine, showing clear improvement over azacitidine alone. So it's been challenging to try and improve on azacitidine alone, and now we have a couple of combinations that seem to be kind of pushing the needle. And so this kind of just speaks to that point of Dr. Diener, that clinical trials make incremental gains. We learn from our mistakes, we take what's successful, and we try to build on it. And so this improved event-free survival, which is generally risk of progression to leukemia. Overall survival was improved from 19 to 24 months, but this was not statistically significant. But the phase 3 trial is already completed and being analyzed now. So this might be an important drug in MDS. Lastly, there were a few questions about immune therapy in MDS. Myeloid malignancies have been a little bit difficult to target with immune therapies, and that's because a lot of the immune therapy requires a really crisp antigen that it can target. And a lot of the antigens expressed on these abnormal myeloid cells are also expressed on healthy cells. So it's been a little bit difficult to target specifically the disease cells, sparing the healthy blood production. But one unique mechanism that I think is going to be interesting is targeting CD47, which is an antibody that is expressed on cancer cells, and it tells the macrophages, which are cells that are part of what we call our innate immunity, and they're kind of swallow up abnormal cells. CD47 is used to kind of silence these eat me signals from the macrophages. And so when you use an antibody against CD47, the eat me signal gets re-exposed, and so the dial shifts in favor of opens up and swallows up the cancer cell. And so drugs targeting CD47 have been showing some good results in studies, first-line treatment of both MDS and AML. At this year, showing some pretty nice responses in patients with MDS first-line treatment in combination with azacitidine. So another combination, and actually very minimal reduction in blood counts, which is frequently a challenge with azacitidine, where the blood counts initially drop. These patients did not have much of a drop in the white cells and the platelets. Everybody has a little drop in the red cells when you start this drug because it suppresses red cell production initially, but that generally gets better with time. And lastly, I will just talk a little bit, one slide about relapse, because I saw there were a few questions about patients being concerned about how do I prevent relapse, especially after a transplant. And I think just monitoring of measurable residual disease has become really hot in AML, and certainly is being looked at in MDS. And it's important that you know what markers are being looked at when you monitor for residual disease, but there have been studies looking at before the actual disease surfaces, if you can detect the mutation that was linked to the MDS and preemptively treat before the blood counts start to change, then you can improve, you can put a number of patients, all shown here in the green and blue, back into where the mutation becomes undetectable. And for those who become MRD negative, meaning the mutation becomes undetectable again after 6 or so cycles of azacitidine, the survival is much better. So surveillance for measurable residual disease in the context of a clinical trial is certainly being looked at both after treatment as well as after transplant. So there's a lot of targets being looked at. I think we've talked about a lot of these in MDS, and just in keeping with Dr. Stiff's request, I just put in one slide about a novel target based on the work that my looking at a novel target in myeloid malignancies called FOXM1. This was the work that was funded by the Leukemia Research Foundation. And basically, this is a gene that's it's a transcription factor, which means it turns certain genes on. A lot of those genes are important for cell division. And so we looked at patients with acute myeloid leukemia who were resistant to chemotherapy and needed multiple cycles of treatment to go into remission, and found that their bone marrows had very high levels of this protein. We were able to quantify this with some digital microscopy techniques and show that it's statistically higher in resistant patients. And that made it an interesting target. So then we try to genetically deplete this protein. And when you do that and you treat the cells with cytarabine, which is kind of a mainstay drug in myeloid malignancy, especially AML, it becomes a lot more effective. And this is just a marker of increased cell death that you can see when you use the same dose of drug, but you take away this transcription factor. So now this sort of is leading to attempts to use drugs to target FOXM1, and there's a few that we are looking at. And with that, I will end, and thank you for the time and the opportunity to present.
Okay, thank you very much. Thank you, both of you. And now comes the question and answer period. And as you mentioned, we do have some questions from participants, but we also have questions that I have come up with. So get ready, brace yourselves. Dr. Khan, you'll be first. What percentage and which patients who have a diagnosis of MDS will develop acute myeloid leukemia, and when will this happen in these patients? And then the second part of that is, if they do develop AML, what is their prognosis, and how would you compare and contrast that to the prognosis of a patient with a typical AML who didn't have MDS?
Right. So the first part of the question, so I think that, as I showed in that diagram at the beginning, it's about a third of patients with MDS are going to go on to develop AML. Again, the increasing incremental gains in our molecular insights, like mutations and genetic abnormalities, are helping us to identify those patients quickly and not overtreat the other 65 to 70% of patients who may have a relatively benign course. When MDS patients go on to develop AML, because it has arisen from that sort of continuum of a long-standing genetic sort of accumulation of mutations, rather than a single time point hit where one genetic lesion like NPM1 or core binding factor translocation, rather than one single lesion where it's a relatively homogeneous disease with one big clone that's pretty susceptible to chemotherapy. MDS that arises from AML is usually genetically a little more complex, often polyclonal with multiple small groups, and then one who's sort of picked up pace. And so usually the challenge is a little bit more challenging to treat with chemotherapy. And so it's been exciting to see that CPX 351 or Vixius has, shown some success here over traditional chemo. I think that patients do acquire mutations in P53. So I think some of these new drugs like APR 246 and hypomethylating agents represent good options. So these patients should be thought about separately.
Okay, Dr. Dinner, what initial tests, including any genetic tests, do you test for when you see a patient with a newly diagnosed AML?
Okay. So we would certainly do chromosome analysis or a cytogenetics, first of all, just for their sort of broader chromosome analysis. But then we do normally a next generation sequencing, which at our institution is about a 40 to 50 gene panel. Certainly things like FLT3 and IDH and NPM1 and CBP alpha are definitely recommended as things we should test for, and also a PML-RR alpha, which we would see in acute promyelocytic leukemia. But then there are many other gene mutations that we would find in an NGS panel, the next generation sequencing panel. So things like DNMT3A, a TET2, EZH2, the P53 gene mutation that we were talking about, as Dr. Khan was mentioning, there are also clinical trials of that APR 246 drug in AML, and some data that magrolimab, another drug that she mentioned, can also have efficacy in AML. So, I guess a pretty broad channel or screen of about 40 to 50 genes.
So these tests obviously are very specialized, and how long does it take to get the results back, and how does this affect starting chemotherapy when a patient's newly diagnosed?
Mm-hmm. So at Northwestern, we're fortunate that we do it in-house in our pathology lab, and usually if I tell them it's a newly diagnosed patient and I need to make a treatment decision, my pathologists are pretty good about getting the answers within about 5 business days. But I acknowledge that that's not always the instance. I would say that probably a lot of places, especially many community hospitals that are sending out the test to a private laboratory to do the testing, it could very well take 2 weeks to make a decision. So, I do think it's important that if you have a new diagnosis of something like AML or even MDS, I think it's worth a consultation at one of the academic medical centers. We're fortunate in Chicago to have 5 of them. And I think, they might be able to get you some answers more quickly such that rather than just starting, let's say 7+3 for an intensive treatment or azacitidine and venetoclax as a less intensive treatment, maybe we would have some more molecular genetic mutation data to help us make a decision or even say, hey, you should consider this clinical trial because we have a new drug in clinical trials that are going to specifically block that mutation.
Okay. Dr. Khan, what is ICUS and how is it managed?
So ICUS is sort of on that continuum of clonal evolution that I showed at the beginning. It stands for idiopathic cytopenia of unknown significance. It's basically when you have an abnormal blood count, whether it's low platelets, low red cells, usually it's one cell line, so either red or white or platelets, and somebody digs around and finds a mutation. So it's usually diagnosed by a hematologist because somebody's been referred for a low blood count and they've gone looking for mutations and they found a clone. A lot of times, in fact, the vast majority, and a lot of this is age dependent, but the vast majority, meaning over 90% of these patients are not going to go on to develop further. Longitudinal studies are lacking. So what we have is sort of knowledge at what age group you tend to have more mutations, and certainly they go up with age. We don't have prospective studies showing that, oh, you know what, if you have this particular mutation with a cytopenia, you may be high risk than another mutation. So we're not that sophisticated in our prospective knowledge of individual mutations, but essentially, usually if you have a cytopenia and a clone, you should probably get a bone marrow biopsy because it's hard to say whether or not you have MDS or not, and MDS remains a pathologic diagnosis. So if you have a cytopenia, meaning a low blood count, and you have a mutation, you may have MDS, and the only way to rule it out is a bone marrow biopsy to look for the physical manifestations that the stem cells are not maturing properly. If you don't have that, then you just have ICUS and you stay labeled that with surveillance blood counts. And if you do have MDS, then we stratify you as I explained and manage. Okay,
Dr. Dinner, if a patient has a favorable risk AML and you decide to just treat them with chemotherapy, how long does the treatment continue? And is this somebody that you would consider putting on the new oral azacitidine chemical?
So if they fall into that favorable risk category, we would treat them typically with just chemotherapy. There's not shown to be necessarily a survival benefit from doing a stem cell transplant as well. And we would usually give them that cycle of induction chemotherapy, which is about 28 days long, and then we would give them often 3 to 4 cycles of consolidation chemotherapy with high-dose cytarabine. Each of those cycles is about a month long as well. So that's going to be another 3 to 4 months of treatment, and then you would be considered to be done. If someone, for some reason, didn't tolerate the 7+3 well, or they just had complications like lots of infections and they've been very weakened by the treatment, that would be an instance where if they got into remission after 7+3, I would consider giving them the oral azacitidine instead of giving them the high-dose cytarabine consolidation. But I think high-dose cytarabine consolidation is still considered to be the standard of care as the best curative treatment. The oral azacitidine was studied as a maintenance that's an ongoing, somewhat indefinite therapy.
Okay, so this is a little complicated, but again, try to simplify as much as you can. Dr. Khan, which patient with MDS would you do a bone marrow transplant? And I'll come back to you, Dr. Dinner, which patient with AML would you do a bone marrow transplant?
So for MDS, it's based on the PSS score, which is based on the blood counts and the percentage of blasts and the chromosomal changes. At this point in time, that's the most well-validated tool we have to pick. And like I said, if that score is higher than 3 to 3.5, we start thinking about transplant. And that, that changes with time. So if a patient is not high risk right now, they may be in a year or two. So we continue to monitor patients low risk also for evolution, and then reassess if we need to. Assessment includes frequently another bone marrow biopsy because, as I explained earlier, the genetic composition of the cells, meaning the chromosomal changes and the percentage of blasts, very heavily part of that score, and that can only be gotten from the bone marrow.
Dr. Dinner.
So first of all, obviously we need to make sure that they are fit for transplant. So not everyone and anyone can get a transplant. We want to make sure that they are strong enough, they have the good energy, and ability to go through a transplant, just because it can make them quite ill, and we could end up killing someone with a transplant rather than managing to save them in the end. So that's the first component. Then I would say anyone who failed to respond to their initial chemotherapy, that is certainly a higher risk feature, and those would be patients who, even if they were initially in the favorable risk chromosome or genetic category, we would recommend a transplant for them. We would also consider it in someone who is MRD positive. So as a specific example, patients who are NPM1 positive are generally considered to be in the favorable risk category, but there's very specific data that has shown if those patients are MRD positive after their initial chemotherapy, they're going to have worse outcomes. And so that would be someone that would benefit from a transplant. Otherwise, usually for someone who's in that intermediate risk group, normal chromosomes or having certain genetic changes that we don't know the prognostic significance of, or if they're in that unfavorable risk group, meaning they have complex chromosome changes or maybe things like a P53 mutation or a FLT3 mutation, those would be examples where we would definitely recommend a stem cell transplant.
And so one of the questions actually that came through was a patient who had intermediate category, and he or she wanted to know, was it getting easier to make decisions about transplant or not based on some of this genetic profiling? In other words, can we winnow down the intermediate group and shove half of them into the poor risk group and half of them into the good risk group and be done with the intermediate risk group?
So yeah, I saw that question. So it's 4 years since you were diagnosed, and I don't think we're there yet. I think we've identified a lot more genetic abnormalities. I think we've had some studies, as I mentioned in my talk, that are showing certain things are more favorable prognosis, some that are showing something might have a bad prognosis. But while there are certain mutations that we know, like a P53 mutation, for example, is bad, or an NPM1 mutation is good, there are a lot that we don't have consistent data on, and I don't think that those are necessarily strong enough data to direct us yet in terms of really whittling down that intermediate risk category. We still have a lot of patients that fall into that group.
Okay. Dr. Khan.
Sorry, can I add one thing to that? Sorry. I just wanted to add that one of the applications of all this molecular testing is the whole MRD part of it too, that if somebody doesn't want to go through with a transplant, or the physician or patient are on the fence, and you opt to go with chemotherapy, if you have a robust marker that can be followed for measurable residual disease, that might be a good sort of barometer you could use to kind of figure out if the disease is coming back early and then move to transplant. So I think that's another application where we could use it. Okay,
I'll stay with you. Another question from the patients. The patient has been on Dacogen systemic therapy for 5 years, and with the advent of the new combo pill, would you advise this patient to continue on the injections, or would you say switch to the oral medication?
Yeah, so I think that I looked at the study, and basically the studies, both of them, one phase 2 and one phase 3, allowed patients who were on stable doses of the IV therapy. So these were not patients who were untreated patients. So they were patients like yourself. And so I think that it would be a reasonable option because, at least from what both these studies are showing us, the drug levels in the blood are equivalent, the toxicities and the response rate are as expected. So I think it's very reasonable.
Okay, Dr. Dinner, is CAR T therapy ready for treatment of acute myeloid leukemia?
So So it's definitely in development, and there are clinical trials that are opening for acute myeloid leukemia with CAR T cells. We're actually opening one soon at Northwestern University. So there's both CAR T cells that are what we would call autologous CAR T cells, so where we take the patient's T cells and we genetically engineer them to attack the surface of the AML cell, and then there are allogeneic ones where they are sort of what we would call off the shelf, like cells that have been donated by someone else and they've been genetically engineered to target the surface of the AML cell. And as Dr. Khan mentioned in her talk, one of the biggest barriers to immunotherapies in AML has been what do we target on the surface of the AML cell. So like I, for example, showed you CD33 as a target of gemtuzumab, but there have been many different targets where if we block them, because it's a myeloid cell of origin, it can end up blocking things like production of red cells and platelets as well. So that's been the tricky thing. But they are in development. There are ones that are targeting things like CD33, other ones that are targeting CD123, which is also on AML cells. And so you can certainly look for a clinical trial in that area, but it is not near FDA approval, if that's what you mean by prime time.
Okay, and we also have a trial of a BiTE, which is a bispecific antibody in which it combines the business end of both the tumor antigen and your immune cells. And so it basically forces the tumor cells and the immune cells to be in close proximity, and it kind of works like a CAR T cell as well. And this has been proven to be efficacious in early trials in about 60% of patients. Dr. Khan, how does HIV, diabetes, hypertension complicate the treatment and outcome for patients with MDS?
So I think, you know, a lot of these chronic comorbidities like the diabetes, hypertension would factor into the hematopoietic stem cell transplant comorbidity index, which is how we determine fitness, as we've spoken about, for transplants. When someone with high risk, all of these factors get taken into consideration. However, it's really more end organ dysfunction and your functionality that are ultimately the heavyweight factors. HIV is I would say, put in a separate category because of the risk of infection. You know, a lot of these therapies are immune suppressive, and so you know, we do definitely have to be more vigilant and careful about the therapies we use in the setting of HIV. So yeah.
So this question for both. I'll go back to Dr. Dinner, and this is the question we get all the time. How about genetics in the family? If my mom has AML, my dad has AML, or my mom has MDS, or my dad has MDS, what are my chances of getting it? So we'll start with you and ask Dr. Khan the same question.
So there definitely have been studies that have shown that if there's at least 2 first-degree relatives, maybe even less than that. I apologize if I don't remember the exact numbers. But I would say if I heard a family history like that, that would make me wary that there's a higher risk of something running in the family. I would recommend that someone like that have genetic testing done. That can be done at most of the academic medical centers in order to see if there is a familial predisposition to developing things like MDS or AML. So if the person we're talking about does not have a known MDS or AML, they're just the child of someone who had it, you know, I think if it's a case where the parent was diagnosed, it's one parent or one family member who was diagnosed like in an older age, you know, we expect these things to often happen at older age. But I think if we're seeing a pattern where clearly like 2 family members or more have been diagnosed, that raises more concern for something familial. And as I mentioned earlier, we don't want to scare you by talking about things like chromosome changes and genetic changes. Most commonly, these are not things you were born with. These were things that you acquired during the course of your life, and we wouldn't expect you to have acquired or inherited them from your family members. We wouldn't expect you to pass them on to your children. But I think if we're hearing that there are, you know, at least 2 or more family members that are having a history, that does raise some alarm that there should be a familial evaluation.
Okay, Dr. Khan. Same question, genetic risk to MDS in the family.
So I think one of the other things and I've recently seen a few patients with this is young presentation of disease. So as I talked about, MDS is a disease of the elderly, usually after age 60. So in dealing with younger 40, I think even in the absence, there's sort of guidelines, I would say, and kind of suggestions that those patients, even in the absence of a family history, should think about getting germline testing, which is basically looking at some tissue other than the blood to see if they had a mutation in a gene that predisposed them to developing MDS. So certainly MDS in the young is very unusual and warrants some looking into.
Okay, we got two questions about some, I wouldn't call them homeopathic drugs, but they're both used to treat parasitic infection, flubendazole and fenbendazole. I'll ask both of you, maybe each have a little bit of knowledge about these. Dr. Dinner, these have been shown in the laboratory to have anti-tumor effects for a variety of tumors. What about their use clinically? One of these drugs is used to deworm dogs and is available on Amazon or probably pets.com or whatever. Would you advise somebody with AML and or MDS to take these drugs?
So, yeah, I had seen this question sent in earlier, and actually there were two questions about these, so it must be sort of a hot topic out there. So I have to admit, I had not heard of these drugs until it was brought up in these questions. So I did look them up, and I specifically looked on clinicaltrials.gov to see if there are any active trials going on with them in leukemia or MDS, and I didn't see any listed. I also couldn't find, well, I did see that, yes, there's anti-cancer activity of these drugs reported. I didn't see that specifically it was seen in AML or MDS cell lines in the laboratory. So I don't know that there's any particular data to favor that drug in these myeloid diseases. What I would recommend is anything should be done in the setting of a clinical trial. You should not be buying these on Amazon or whatnot and taking them yourself. Let's not follow the model of our president and take some hydroxychloroquine. So, you want to do it inside of a clinical trial. You want to talk about it with your physician. The other important thing to keep in mind is, always tell your doctors what you're taking, because there can definitely be a lot of drug interactions between the chemos that we put you on and other supplements or things that you choose to take. So, it's important we know exactly what's going on.
Dr. Khan?
Yeah, I don't have a lot to add other than the fact that also a lot of these, even if they are having some target inhibition, it really needs teasing out at what doses they're inhibiting the target and what other off-target effects they're having. So, again, dosing is very difficult when you're buying these sort of random formulations. So I'm just echoing what Dr. Dinner said.
Okay, next question has to do with relapse. Both of you can answer this. Again, Dr. Dinner, I have AML, I've gotten chemotherapy, and whether or not I got a transplant, if I'm going to relapse, when am I likely to relapse? How often should I be seen and followed up?
So most commonly we see relapse within the first few years. Generally, what I recommend for my patients is that after they've completed treatment, that we would see them, let's say, once a month for the first year, and then I would space it out to every 3 months if they're doing well, and then after that, in the third year, let's say every 6 months, and then after that, maybe space it to once a year. Basically, you would expect that after those first 3 years, the risk of relapse should go down, but I think it's always good to sort of once in a while, at least once a year, check in with your hematologist oncologist for some blood counts. And obviously, if you're noticing any new symptoms, things like fevers, chills, unexpected weight loss, big lymph nodes, just generally feeling poorly, and it doesn't just seem like a regular cold, come in for a CBC sooner.
And Dr. Khan, if somebody's responded very nicely to azacitidine and their bone marrow looks great, and do you put them on a maintenance program? And if not, when are they likely to relapse?
So generally, similar to AML, happen within the first few years. Maintenance post-transplant is something that at this point in time is very physician dependent. I would say there's not a clear-cut guideline about using it. I think, the myelodysplastic thing, as I alluded to earlier, with if you have certain, not everybody has a good marker for a mutation that tracks well with their disease, but certainly using that for surveillance in MDS is a really good idea if you, again, have a mutation that's trackable, because not every mutation is present at the time of relapse. So monitoring that and then preemptively treating with hypomethylator or some other targeted agent, depending on if there's a trial looking at that, has been looked at after azacitidine, after transplant, and definitely in patients who you can push back into that remission, they do better. So I think that kind of surveillance is useful, but it's not standard of care, but a lot of it's being done in the setting of clinical trials. And I think a lot of academic centers, if you have, again, a reliable marker, will do it.
Okay, well, that wraps it up. We're a few minutes over. I know that all of you have been very patient with us, and hope that these additional questions at the end help to explain some of the nuances that we as physicians go through every day when we see patients. I'd like to thank our two panelists tonight. Excellent talks, excellent answers to the questions. They are the young shining stars of hematology oncology in Chicago, and I sincerely appreciate their taking their time, their evening, if you will, to share their vast experience and knowledge with you. And then on behalf of myself and the other team members of the Leukemia Research Foundation, again, thank you for participating in these three events, and I'll turn it back over to Carrie for some final comments.
Yes, thank you so much, Dr. Stiff, for moderating this evening's event. And thank you again to Dr. Khan and Dr. Dinner. We are planning our annual town hall meeting, which is a Q&A style forum, kind of similar to what we had here at the very end of the program. So we will be sending all of you information about that as we have it together. It's scheduled for January 31st. So thank you all for joining us, and have a wonderful evening.